Hello and welcome everyone back to the session 3 for today of case-based scenarios in medicine. My name is Dr. Jhanvi and I am going to be discussing a few case-based scenarios that can come for your exam from medicine. They are topics that are discussed and asked in the exam very often, and I have created some interesting case scenarios for you all so that you all can study in a clinical manner. So first of all, I hope that all of you all are able to see me and hear me well. I'm able to see your messages on the chat box, so please leave a thumbs up if you are able to see me well. Yeah, so on the chat box, I can see that the streaming is fine and you guys are replying. So let's begin with our class for today. Welcome to Unacademy. It is India's largest learning platform. I am a gold medalist in anesthesiology, and this is the Telegram channel where we post the links to all our classes. So the name of the Telegram channel is Let's Crack NEET PG, and here you will be able to find all the links to our classes. So please make sure you're following me over here so that you're notified about my classes. We also have the NEET PG All India mock test on 26th of February at 9 a.m. for you guys. So this will help you evaluate your performance in the upcoming NEET PG exam. Make sure that you enroll for this test. You have to use a code. So you can use my code Dr.Jhanvi Live to enter into this test series. And you will be able to get all the questions with its solutions as well as your ranking at the end of the test for free. The Plus subscription on Unacademy will help you get access to live and recorded classes. You can learn from India's top educators. You can compete in live tests and quizzes. So you can study on the device of your choice, and you can access our question bank with 25,000 plus high yield questions. The iconic subscription is a partnership between Unacademy and Prep Ladder, which will help you get the recorded lectures of Prep Ladder along with the live lectures of Unacademy. These are all our FMG December toppers. We also have the educator curated test series in which we have our awesome educators with simple tests based on their expert subjects, and you can access all of them for free. In our special classes that is there on the Unacademy platform, you can use interactive sessions. You can raise a hand, speak to the educator live during the class, and you also get the PDF of the lecture notes at the end of the class. These are all the batches that we have right now. So we have the Target Next 2023 subject wise batch, the NEET PG 2022 all educator revision batch, the Focus FMG 2022 comprehensive batch, and the Focus FMG December 2022 comprehensive batch. So these are all the batches that we have currently. Then we also have a few offers on the NEET PG Plus subscription. So if you see that these are highly discounted rates for the NEET PG Plus subscription. And we also have the Iconic Bonanza offer in which we have a big discount on Iconic subscription. And plus, to get some extra discount in the class, you can also use my code Dr. Jhanvi Live, which will help you get 10% off on your subscription. Okay. So with that, we come to our first question for today. A newborn child has tachypnea, cyanosis, and bowel sounds are heard in the chest. He shows the following X-ray. What is the probable diagnosis in this child? Single lung syndrome, traumatic pneumothorax of delivery, congenital diaphragmatic hernia, or sigmoid volvulus? Able to see me and hear me now? Is this okay? Fine now? Is the streaming fine now, guys? Please leave a thumbs up in the chat box. Okay, so what is wrong over here? You can see that there are multiple bowel loops, and these multiple bowel loops have herniated out of the thoracic cavity. Okay, so as you can see, this is nothing but simply congenital diaphragmatic hernia. Now, the question that I have for you guys is, congenital diaphragmatic hernia is common on which side? Is it common on the left side or is it common on the right side? What is the name of the congenital diaphragmatic hernia that occurs on the left side, and what is the name of the congenital diaphragmatic hernia that occurs on the right side? So I want you guys to answer this for me, both of this. I think the streaming is absolutely perfect now. So can you tell me? All right. Yes, Akash, absolutely correct. So congenital diaphragmatic hernia is more common on the left side, and that too you have the left-sided hernia, which is called as the which hernia? Left side is called what? Left side is called as Bogdalic hernia, and right side is called as Morgagni's hernia. Left side is called Bogdalic, right side is called Morgagni's hernia. Okay. So in how to remember this? Remember in Bogdalic, you have an L over here. You have an L, so that's how you can remember Bogdalic is on the left side. And whenever you think about Morgagni, it has a R over here. So Morgagni is present on the right side. So that is one of the tricks to remember which hernia is on which side. Okay. So how will this child present with? This child, when he is born, he will have difficulty in breathing. So he will have tachypnea, cyanosis, because on the side of the hernia, wherever the bowel is going up, it is going to completely compress the lung on that side. So as a result of this, that side lung will be useless. So the child will be breathing only from the other lung. Okay. So because of that, there's not much oxygen that is available to the child. So he will have cyanosis and he will have respiratory distress. Okay. When you auscultate the chest cavity of the child, you will be able to hear the gurgling sounds of the bowel in this case. Can anyone tell me what is the treatment over here? No staphylococcus, it cannot present with tamponade effect. Now, can you tell me what would be the treatment over here? Anyone? What would be the treatment for this disease? So I'll tell you what will be the treatment. The treatment will be, first thing you will do is you have to deflate the bowel. Okay. So to deflate the bowel or to decompress the bowel, first you will insert a Ryle's tube. Once you insert a Ryle's tube and decompress the bowel, the next thing that you will do is you will intubate the child. Okay. So when you intubate the child, what will happen? On intubating the child, you can ventilate the lung. The lung that is on this side, on the left side, on the side of the hernia, can be ventilated, and by ventilation you can expand the lung by positive pressure. So when you expand the lung, automatically all this bowel that is there, it gets pushed down back into the abdominal cavity. So that would help in reducing the symptoms of the child. Of course, for treating the patient, you will have to take him up for surgery, and you will have to put all this bowel back down into the abdominal cavity, push it back, and then you will close it by putting a mesh at the area of the defect. So wherever the defect is there in the diaphragm, you close it with the mesh so that the bowel does not go back into the thoracic cavity. All right. Okay. Moving on to our next question. What would you do in this question? What would you do in this case? Will you intubate the child? Will you insert a Ryle's tube and decompress the stomach? Will you do both A and B, or intervention is required only if there are symptoms? The contents are coming out through the diaphragm only because the opening or the defect is in the diaphragm. That's why. Okay. So Akash is saying we'll do both A and B. Staphylococcus is saying the same. Absolutely correct, guys. So we will be doing both of them. We will insert the Ryle's tube to decompress the stomach and the bowel, and you will intubate to expand the lung. And then after both of these things are done, we will stabilize the child, and then we will take him up for surgery. All right. Moving on to our next question. A child is posted for elective surgery to correct posterior urethral valve. The mother was asked to follow starvation guidelines strictly. As the child was crying, she gave him half a glass of cow's milk. By how much time does the surgery need to be postponed? 2 hours, 4 hours, 6 hours, or 8 hours? Okay, there is a big confusion over here between 4 hours and 6 hours. Alright, so let's discuss the starvation guidelines of all the foods. So what is the starvation guidelines of clear liquids? By clear liquids, I mean water or black tea or coffee, that is tea or coffee without milk, or you can even say coconut water, but without the malai, huh? So what is the fasting guidelines for this? The fasting guidelines for clear liquids is nothing but 2 hours. Okay. Then next we have closest to clear liquids, something that gets easily digested is human milk. Okay. So the fasting guideline for breast milk is how many hours? It is 4 hours. Okay. After that, the next that we have after clear liquids and breast milk is, what do we have after clear liquids and breast milk? We have cow's milk, formula milk, or a light meal. Now, what do you mean by a light meal? Light meal literally means nashta. Okay, so like simple things like non-fatty plain biscuit, Mary biscuit, glucose biscuit along with tea, or if you want to have one khakra. Okay, so all that is light meal. So you can have this up to 6 hours before the surgery. And the last thing that we have is a full fatty meal. So full fatty meal means you can take the child only after 8 hours. Okay, so to digest a full fatty meal, it takes 8 hours. So now, since the child is had half a glass of cow's milk, even if it was 1 spoon of cow's milk, the starvation guidelines remains the same. Okay, so he's had half a glass of cow's milk, so you will make him wait for 6 hours at least. You'll postpone the surgery by 6 hours. Okay, so I have a question for you guys. Suppose I do not give the child this starvation extra time, and I say, no, let's take him up for surgery now, I'll induce the case, I'll give GA to this patient. So what will happen in that case? Suppose he has just had cow's milk and the mother is like pleading to me, the surgeon is saying, nahi, late ho jayega, madam, please case le lo. And I say, okay, fine, I will induce the patient and I will give GA. What is the problem that can happen in this child? Yes, very good, Akash. So if we induce this child without adequate starvation, all the food, all the cow's milk that is now there in his stomach can come up and it can cause aspiration pneumonia. It can go into the lungs and it can cause aspiration pneumonia, and the child can actually die of aspiration pneumonia. So we should avoid this from happening. All right. Okay. A mother is concerned about her 6-month-old child's growth and development and wants to follow the milestone chart. What all should her child have achieved by now? So this is based on milestones. I hope pediatric milestones you guys have revised. I want to see how well you guys know it. So by 6 months of age, what all should the child have achieved? Crawling and bisyllables, walking and cooing, monosyllables and supine to prone, or bisyllables and pincer grasp. By 6 months, what should the child be able to do? Okay, absolutely correct. All of you all who have mentioned the answer as C, that is right. So by 6 months of age, the child should be able to talk in monosyllables and he should be able to move from supine to prone. Okay, so that is the right answer. Now, all of you who have difficulty in remembering the milestones, this is the link to the YouTube video on which I have given you all an easy video how to remember the milestones, and you will find this on YouTube only. You can go and watch it at 1.5x the speed so that you can revise your milestones. Okay, I hope you guys enjoyed this video. If you don't have this link, you can just directly put Dr.Jhanvi milestones Unacademy and you will be able to find the video. All right. Okay. Yes, milestones are very, very important for the exam. All right. So next question for us: while inserting a central venous catheter in the IJV in a tracheostomized patient, he gets severe hypotension, tachycardia, and desaturation. What should be the immediate next step? ICD insertion, needle thoracocentesis in second intercostal space, needle thoracocentesis in fifth intercostal space, or intubation? Guys, we'll be continuing with this case-based series every day, and it will be at 6:30 p.m. every day. So I'll see you at 6:30 p.m. except on 16th and 17th. So that is on 16th. I'll be taking it in the morning itself. I'll be putting the links on the Telegram group. Okay. So make sure you come for it because we'll have a bunch of case-based scenarios which will be different every day for you guys. All right. So can you tell me what is wrong with the child over here? What is wrong with this patient? You're putting a central line in the internal jugular vein. Now, why have they added it as tracheostomized patient? Okay, so they have just added tracheostomized patient. This is to confuse you. They have nothing to do over here. It has nothing to do. It is just to confuse you. In a tracheostomized patient, if you are getting severe hypotension, tachycardia and desaturation while you are putting a central venous line, anytime, that means you have caused a pneumothorax. Okay. And what kind of pneumothorax is this? The pneumothorax that it is a tension pneumothorax. So to relieve the tension pneumothorax, you can do two things. One is you can do a needle thoracocentesis and second is you can put an ICD. It takes time to insert an ICD and it also requires skill and expertise from a surgeon. So that's why the best thing that you can do is immediate next step when they're asking you, immediate next step, take a wide bore IV gauge and use it to do a needle thoracostomy. Now, the question that I always get is where exactly should you do the needle thoracocentesis? Should you do it in the second intercostal space, mid-clavicular line, or should you do it in the fifth intercostal space, mid-axillary line? So can you guys tell me what is the correct answer between the two? Because I can see a lot of you are confused over here. Yeah, so if age of the patient is not mentioned, then you should just assume that it is an adult. Always, that is the golden rule. If the age is not mentioned, assume that it is an adult. Okay, so the correct answer over here is needle thoracocentesis in mid-axillary line, fifth intercostal space, which is the space where we do needle thoracocentesis in adults. In second intercostal space, mid-clavicular line, this is where we do needle thoracocentesis in children. All right. Okay. Now moving on to our next question. A patient in the emergency medical services is having a seizure. There is no bite block available. Which of the following can be used instead to prevent a tongue bite? All right. Okay. So what can you use to prevent a tongue bite over here? I want you guys to first answer what each of these instruments are. So can you tell me what is A, what is B, what is C and what is D? The correct answer over here is A. But what is A? What is B? What is C and what is D? Batao. Very good, Ayush. So A is nothing but a oropharyngeal airway. This is also called as Giddle's airway. Oropharyngeal airway or Giddle's airway. What is B? B is an endotracheal tube. Okay. What is C? C is a nasopharyngeal airway. And what is D? D is a LMA. Okay. Yeah. So these are all the four things that we have over here. Now, if you do not have an airway to, if you do not have a bite block to prevent tongue bite, what you can do is instead put an oropharyngeal airway or a Giddle's airway in between the teeth. So that will prevent the person from biting his own tongue. Okay, so to prevent tongue bite, you can use an oropharyngeal or a Giddle's airway. Alright, moving on to our next question. A concerned mother notices that her child turns blue whenever he is crying. She takes him to the pediatrician who asks for a 2D echo to be done to rule out a heart disorder. The echo findings state infundibular stenosis with right ventricular hypertrophy and a ventricular septal defect. What condition are they talking about? Hypertrophic cardiomyopathy, patent ductus arteriosus, tetralogy of palate, primary pulmonary hypertension of the newborn. Excellent. So all of you all know TOF very well. Okay. So if you all know TOF very well, tell me what is the part of tetralogy of Fallot? What are the four things that are present in tetralogy of Fallot? Please tell me. What all is present in tetralogy of Fallot? Morphologically, you have right ventricular hypertrophy. Then you have pulmonic stenosis, pulmonary artery hypertension because of the pulmonic stenosis. Then next you have overriding of the aorta, and you have a ventricular septal defect. When I say pentalogy of Fallot, what is the extra thing that is added? Pentalogy of Fallot, what is the extra thing that is added? Batao. Yes, absolutely correct. So in pentalogy of Fallot, the extra thing that is added is ASD, atrial septal defect. Okay. So this is about tetralogy and pentalogy of Fallot. What is the X-ray appearance in TOF? How does the heart look on X-ray? Everyone knows the answer to this. And is TOF a cyanotic or an acyanotic heart disorder? Yes, absolutely correct. There is a boot-shaped heart. And is it a cyanotic or an acyanotic heart disease? It is a cyanotic heart disease. Very good. Okay, now another question for you guys. Can you tell me what is a TET spill? What happens in a TET spill? Anyone? Right to left shunt. Okay. Yeah. So whenever the child starts crying, okay, so as a result of this, what will happen? There will be excessive sympathetic activity in the child. Because of the sympathetic activity, your pulmonic stenosis that was there, it will worsen. So when your pulmonic stenosis worsens, there will be movement of blood from the right side of the heart to the left side of the heart. So there will be a right to left shunt. So that will add to the cyanosis. Okay, so that is called as a TET spell. So how do you break the TET spell? To break the TET spell, first of all, बच्चे को शांत करना पड़ेगा. Since the child is crying and he has increased sympathetic activity, first you have to calm the child down. Okay, for this, either you can naturally calm the child down or you can give him drugs like morphine. Okay, then after that, once you calm the child down and stop him from crying, you can give him a knee chest position. Okay, so you can give him a knee chest position. So that will also help in reducing the shunt fraction. Okay. And other than that, what are the other things that you can do? Okay. Now, when we are talking about the treatment for TOF, can you tell me what is the 3 surgeries that are done in the treatment of TOF? Can you tell me what are the 3 surgeries that are done in the treatment of TOF? You have Blalock-Taussig shunt, you have Watterson shunt, and you have Potts shunt. Okay, so those are the 3 shunts that you should know about, and especially you should know which is the most commonly done shunt in TOF, and that is your Blalock-Taussig or BT shunt. Okay, yeah. Moving on to our next question. A mother has just delivered her baby by lower segment cesarean section under general anesthesia. Okay, so she's been operated under general anesthesia. Once the child is handed over to the father, he notices that the baby is a little lethargic, he is not crying, and he is turning slightly blue. He informs the neonatologist immediately. Which drug can be implicated in this condition? Propofol, scoline, paracetamol, or fentanyl? Okay. Chappagadi and Ayush, PSK, Staphylococcus, everyone is mentioning fentanyl. That is absolutely correct. Okay. So what is happening? You have given general anesthesia to the mother. So whatever drugs you give in general anesthesia will cross from the mother to the and reach the fetus through the placenta. Okay. So when the drugs cross and go to the fetal circulation, they will act on the fetal organs. Now, what is the drug that can cause lethargy and he's turning slightly blue as a result of cyanosis. So that is why he is having respiratory depression. So there is lethargy and respiratory depression, and overall the child is looking a little down. So this is mainly because of the opioid effect. Okay, so if you use opioids while inducing a patient under general anesthesia in LSES, then you can tend to have this kind of situation. Okay, now propofol, it does not act, it gets metabolized in the body very quickly, so it does not act for a very long time. Scoline again is a very short acting drug and it does not cause any problems in reaching the child. Paracetamol will not cause lethargy. So opioids is the only thing that is highly lipid soluble, easily crosses the placenta and goes inside the child, and it causes respiratory depression. All right. Okay. Moving on to the next question. A newborn baby is noticed to have respiratory distress during breastfeeding, as a result of which there is poor feeding. The pediatrician is suspecting tracheoesophageal fistula. What test can be done to confirm this? Upper GI scopy, X-ray, passing a Riles tube, or barium swallow? All right, so all of you are giving the answers for this. So can anyone tell me what is wrong over here? So the child starts coughing and he starts having respiratory distress whenever he is breastfeeding. So why does that happen? So if this is your esophagus and this is your trachea. Okay, so I'll just mention over here, this is your esophagus and this is your trachea. So there is a connection between the two of them, and that is called as tracheoesophageal fistula. Okay, so this is your tracheoesophageal fistula. So whenever the child is breastfeeding, the milk can pass from the esophagus inside the trachea and it can go here and it can cause coughing and respiratory distress in the child. Okay, so how do you confirm this? The confirmation of this disease is by trying to pass a Riles tube. So when you try to pass a Riles tube through the esophagus, it will go and it will get coiled over here. It will go here and it will get coiled over here somewhere in the fistula and in the trachea. So that is the best way of, and when you take an X-ray, because your Riles tube is radio opaque, you will be able to see the coiled Riles tube over there. Okay, so that is how, this is another test that, another thing that you need to remember is this one of the most important clinical bedside tests. Okay, so you can pass a Riles tube and you can confirm this diagnosis. All right. Okay. Next question. After a motorbike accident, Raju was admitted to the nearest hospital with GCS of 5/15, heart rate of 76 beats per minute, BP of 130/80. The following is a CT scan. What could be the diagnosis? Contusion, pneumoencephalus, diffuse axonal injury, or intraventricular hemorrhage? Ayush, no, this is not a test of confirmation. If you want to confirm the presence of a tracheoesophageal fistula, you can do an upper GI scopy and you can see the presence of the fistula. But that is the quickest and the easiest bedside test to be done. Okay. So, can anyone tell me what is the problem in the CT scan? What can you diagnose in the CT scan? So can you guys diagnose the CT scan for me? What exactly is wrong in this? Okay, so this is a normal CT scan. There's nothing wrong over here. Okay, a lot of you get confused and you all say that there is intraventricular hemorrhage, but you cannot see any blood in the ventricles over here. Okay, so what is this part? Is this not pneumoencephalus? Is this not pneumoencephalus? No. So this is air in the paranasal sinuses. It is not pneumoencephalus. Okay. So if you have a normal looking CT scan, you're not able to see anywhere where the blood is there or there is any kind of injury to the bone, nothing. Okay, but if you look at the condition of the patient is having a GCS of 5 by 15. So this is not explained. You can't see anything wrong with the CT brain, but the GCS is 5 by 15. So in this case, the only answer is diffuse axonal injury. So what happens in diffuse axonal injury is, if this is your neuron, for example, so there will be shearing stress injury. So what happens is your axons that are there, they get affected. Okay. So individual axons get affected, and as a result of this, you get the patient in such a bad situation, and many a times the patient is not even able to come out of it. Okay, so this is what happened to one of the greatest car racers of all times. So if you are not able to explain the clinical condition of the patient when the CT is looking normal, think of diffuse axonal injury and overall brain edema. The best way to diagnose this disease is by doing an MRI of the brain. So in the MRI, you will be able to see the edema. Okay. All right. Moving on to the next question. A patient is undergoing lower segment cesarean section and receives 7 PRBC for 2 liter blood loss. 7 PRBC means PRBC is packed red blood cell. In recovery, she develops hypoxemia, dyspnea, cyanosis, fever, tachycardia, and hypotension. A chest X-ray is given in the image below. She has received blood 1 year ago too, but that was uneventful. Give the diagnosis. Mismatched blood transfusion, Trali, TACO, or anaphylaxis. Yes, I will answer Ayush's doubt. So actually, the reason I gave the answer over there as passing a Riles tube is because when I was making the questions, I had added the word bedside clinical test over there. But if I look at the question, if we go back, I think that bedside thing did not get added. Yeah, so that's why I wrote it over here. Bedside test that can be done to confirm this. Okay, the only bedside test that can be done to confirm this is passing a Riles tube. So sorry on my part, it's an incorrectly worded question. Okay, so what about this, guys? Ravi Kumar is saying Trali, Akash, PSK, Karthik, all are saying Trali. That's the incorrect answer. Please read the question carefully again and then answer. Okay, very good. So all of you who have answered it as taco, you're absolutely correct. Now, can you tell me what is the full form of taco? Not the tacos that we eat. What is the full form of trali and what is the full form of taco? Okay, so the full form of trali is transfusion associated acute lung injury, and the full form of taco is transfusion associated circulatory overload. Okay, so let's have a look at each and every line of this question. So patient is undergoing LSCS, receives 7 PRBC for 2 liter blood loss. So this is nearly 1 PRBC will be around 280 to 300 ml. So you have given almost 2 liters of blood to this patient. Okay. In recovery, she develops hypoxemia, dyspnea, cyanosis, fever, tachycardia, and hypotension. So something is wrong with the lungs. They are not able to pick up the oxygen. Now, her chest X-ray is given in the image below. She has received blood 1 year ago also, and that was uneventful. So what are they telling you from this part? If she has received blood before, that she is not allergic to blood. Okay, so anaphylaxis can be ruled out. Mismatched blood transfusion, she would have had reactions immediately And these reactions present with the patient having excessive bleeding and the patient complaining of pain at injection site or pain at blood transfusion site. So all these are not given. So your only options over here are trali and taco. Now, if you look at the X-ray over here, you can see that the blood vessels, pulmonary vessels that are there, that they are completely dilated. Okay, so why are they dilated? That is because they are overloaded with the fluid. Why are they overloaded with the fluid? Because you have given so much of blood in them. So the answer over here is transfusion associated circulatory overload. Anyone, what is the treatment of this condition? Can you tell me the treatment of this condition? Treatment of this condition, what will you do in this patient? Okay, so you will give diuresis. Okay, you will give diuretics like injection Lasix, and you will help in removing the excessive fluid from the body of the patient. All right. Okay. Next one. This is an X-ray post central line insertion in the emergency room. What is the next step? Start vasopressors medications through the central line. Reinsert on the opposite side. Ask for radiology consult on the X-ray. Withdraw and reposition the central line. Ayush, okay. Ayush, for trali, you will have similar presentation: hypoxemia, dyspnea, cyanosis, fever, tachycardia, and hypotension. But the patient will not, first of all, not have received so much blood. She would have received only 1 or 2 packed RBCs. The second thing that happens in trali is that it is nothing but an immune complex deposition. So there is an antigen antibody reaction, there is a reaction against the blood components, and those immune complexes get lodged into the pulmonary vessels, giving rise to a flare up of the lungs. Okay, so and the very important thing is the timing of trali. So can anyone tell me what is the timing of trali? So the features of trali that are there, they occur in how many hours? They occur in 6 hours post the transfusion of the blood. Okay, so that is the timing that is important over here. Here they have not given anything about the timing of the occurrence of the symptoms. Okay, all right. This is an X-ray post central line insertion in the emergency room. What is the next step? Start vasopressors medications through the central line. Reinsert the central line on the opposite side. Ask for radiology consult on the X-ray, or withdraw and reposition the central line. This is not morning question phase. This is different. If you feel this is the morning question, then have a good look at the X-ray. Answer is not A. Try to trace the central line. Okay, so let's trace the central line over here. So if you look over here, the central line is coming from the IJV, and then it is going to the opposite side and it is curving like this, and the tip is not at all reaching anywhere near the heart. Okay, so this central line has now curved and it is not reaching anywhere near the heart or the SVC. So what are you supposed to do? You're never, you don't need to ask for a radiology consult on the X-ray. There's no need. As an anesthetist, as a doctor, you can read X-ray on your own. You should not be starting vasopressors or medications through this central line, because the position of the central line is incorrect and the central line is coiled inside. Now, you have two options over here. Either you can reinsert the central line on the opposite side, or you can withdraw and reposition the central line. Now, remember, with the central line, you should never withdraw it or reposition it, because while withdrawing it, if you just keep it like that, A, you can either increase the coiling, or B, you can cause perforation of the vein through which you have put it. Okay, so the simple thing to do with a central line, always, if you feel that it has not gone smoothly, if you feel that it is not in the correct place, you will just remove the entire central line and repeat the procedure on the opposite side. Okay, so you remove the central line and reinsert it on the opposite side. So that is how you will deal with a central line which is not correctly placed. Okay, all right. While removing the central venous catheter, the tip breaks off and migrates inside. So you were removing this line and now the tip has broken and the catheter has migrated inside. What should you do in that case? Reassure the patient and ask him to consult if any symptoms. Serial X-ray every week, serial ECG every week, send to interventional radiology immediately. Staphylococcus, yes, I can explain again. So remember, if a central line is coiled anytime or if it is not in the position that you want it to be, it is not straight, it is not reaching the heart or the SVC, then you should entirely remove it and put it on the opposite side. You should never withdraw, reposition or play with the central line because there can be many complications with that. Okay. All right. So now you were trying to remove the central line and the tip of it has broken off and it has gone inside. So what should you do in that case? So PSK and Ayush are saying D. Atmesh is still watching the previous questions. All right. So what happens when a central line tip breaks? Okay. This is your right atrium light. This is your heart and this is your SVC. Now imagine this is your central line that is coming from here. And the tip of the central line should lie here at the junction of SVC with the RA. Suppose the tip of the central line breaks from here. What will happen? The central line tip that has broken off will enter into right atrium, right ventricle, and it can go into any of the pulmonary vessels or just stay in the heart. Okay? Yeah. That was the guide wire, not the stellate. Okay? So what happens is, now when this part of the central line or even the guide wire for that matter sometimes breaks off and goes inside, it can touch the walls of the heart. When it touches the walls of the heart, what does it do? It causes arrhythmias in the heart. Now, if there are frequent arrhythmias in the heart, the patient can get hemodynamically unstable. Okay, so his BP can go down. You can have a sudden fall in blood pressure, and this patient can even end up with a cardiac arrest. And this guide wire or the part of the central line will always remain in the circulation and it can keep coming back and causing more and more arrhythmias in the patient, just making him stable. Okay, so you cannot just leave it like that. You cannot just watch if it is causing complications or not and then accordingly take a call on what to do. You have to remove that part of the central line. So you can send the patient to interventional radiology and they will help in removing the central line tip that has broken off or the guide wire. All right. Okay. Next one. Now this patient is having very bad luck. So you've removed the central line and he is admitted again and a central line is put through the left side this time, left IJV. It has gone in with ease, but patient is complaining of some chest discomfort. ECG shows intermittent Vpcs and X-ray shows this. What is the diagnosis? Start vasopressors and medications through the central line, ICD insertion, CT thorax or needle insertion in 5th intercostal space mid-axillary line. Chappakadi Ravi Kumar, wrong answer. Pairs, wrong answer. Yes, Akash, wrong answer. Very good. Okay. So the correct answer over here is D, absolutely correct. All of you who have marked the answer as D. So if you see in the question, the IJV has gone inside, but the patient is having some pain in the chest and he's also having intermittent VPCs and X-rays. So if you look at the left side, you put a left-sided IJV, correct? Left-sided IJV. So if you look at the left side, what can you see different from the right side? First of all, there are no lung markings over here. Second of all, the diaphragm on this side is pushed down. Okay, so this is also called as the deep sulcus sign. And the left side looks very, very dark as compared to the right side. And the patient is also complaining of some discomfort. So this is nothing but a left-sided pneumothorax. Now, what type of pneumothorax is this? So since the patient is getting VPCs and chest discomfort, this could be a tension pneumothorax. So you have to do something which is an emergency. Remember, whenever they ask you what has to be done in a pneumothorax, the first thing you do is needle insertion. Okay. or needle thoracocentesis. The second thing that you can do is call the surgeon and get an ICD put in. But the first emergency thing or first line will always be needle insertion. Okay? Alright. A newborn baby is noticed to have respiratory distress during breastfeeding, as a result of which there is poor feeding. The pediatrician is suspecting tracheoesophageal fistula. What bedside test can be done to confirm this? So this is exactly the question I wanted to ask you guys. I think in the previous question it did not get converted, so that's why I'm sorry about it. So passing a rice tube is the bedside test that you can do to confirm it. All right. How does a pneumothorax cause Vpcs? So when you have a pneumothorax, there is excessive compression of the heart. Okay, so in the mediastinum you have the air building up because of the pneumo in between the two pleural layers, and the heart gets compressed from outside, so you can have any kind of arrhythmias on the heart because of the compression. So Ayush and Staphylococcus, I hope that this question answers what you guys were asking me before. All right. Next question. A 33-year-old man presented with a slowly progressive swelling in the middle one-third of his right tibia. X-ray examination revealed multiple sharply demarcated radiolucent lesions separated by areas of dense sclerotic bone. Microscopic examination of a biopsy specimen revealed island of epithelial cells in a fibrous stroma. Which of the following is the most probable diagnosis in this case? Adamantinoma, osteofibrous dysplasia, osteosarcoma, or fibrous cortical defect? Okay, Ravi Kumar is saying D. Ayush is saying adamantinoma. Deepthi is saying osteofibrous dysplasia. And then we have Mulai who's saying osteosarcoma. So everyone has given all the possible answers. But the correct answer over here is adamantinoma. Okay. So whenever they give you this kind of obviously you cannot identify very well from the x-ray picture, but if they give you that there is a radiolucent lesion that is separated by areas of dense and sclerotic bone, that is very characteristic of a adamantinoma. And even more characteristic is the presence of the site, first of all middle one-third of the tibia, second the microscopic examination. So the microscopy shows you island of epithelial cells in a fibrous stroma. Okay, so that is very characteristic of an adamantinoma. So that's how you should be able to identify this. This was actually one of the NEET PG questions in the last 2-3 years, I guess. So I hope you guys had revised this and then you would have answered it. Okay, moving on to the next question. Identify the structure shown in the above image. Sorry, in the below image, not the above image. Electrolarynx, esophageal speech, tracheoesophageal prosthesis, or Chicago prosthesis? Yes, very good. So can you tell me this prosthesis is used after which surgery? After which surgery do you use this prosthesis? It is tracheoesophageal prosthesis. It is used for creating artificial speech. And after which surgery do we use this? Hello, Sachidanand Yadav. Welcome to class. Yes, so this is used after CA larynx. So in CA larynx, if you do a total laryngectomy, your larynx is your voice box. So after total laryngectomy, you're not able to speak at all. So in order to make the patient speak, make sure that he does not lose his voice completely, you put this tracheoesophageal prosthesis. So what it does is that it takes some amount of air from the esophagus and it passes it on to the trachea and it helps in producing speech. Okay, so tracheoesophageal prosthesis used for producing speech. Along with that, you also have other ways of producing speech. Do you know what is this? Anyone? Have you seen this before? Yeah, they have a very hoarse voice after tracheoesophageal prosthesis. Anyone? Do you know what is this? Seen before? Since already this question was asked in NEET PG, I thought the next one could be asked now. So this is a battery operated vibrator. You just hold it below over here like it is given in the picture, and it produces vibrations in the lower part of the mouth, in the floor of the mouth, and it helps in producing speech. Yes, so this is called as an electrolarynx. This is called as electrolarynx. Okay. Now, what about the other options? So, esophageal speech is nothing but it is a mechanism of using the air to talk. Okay, so it is not any instrument, but it is a way that is taught to the patients how to use their air in order to speak. Okay, and Chicago Prosthesis is not related to any of these. Okay, a child comes with fever, sore throat, dysphagia, and stridor. This is his X-ray. What is the disease that he is suffering from? Croup laryngitis, posterior pharyngeal abscess, or acute epiglottitis? Atmesh is saying posterior pharyngeal abscess. Faiz and Ayush are saying acute epiglottitis. Akash is also the same. Alright. So absolutely correct for all of you who are saying that this is acute epiglottitis. Correct. So this is a thumb-shaped sign that you see over here. This is called as thumb sign on X-ray. So thumb sign is seen in case of acute epiglottitis. Why do you see this? Because of the inflammation or edema of the epiglottis, you see this thumb sign. Okay. Now, what is the most common organism that causes acute epiglottitis? And what is tripod sign seen in acute epiglottitis? Tell me these two answers. Yes, so the most common organism causing acute epiglottitis is H. influenza. Guys, please don't say strep because strep pneumonia, it always comes in the options, but that is never the correct answer. Okay, it is still H. influenza. Okay, other than that, what is tripod sign? Tripod sign means the child will be having acute respiratory distress in case of acute epiglottitis. So he will be standing on his hands like this and he will be breathing with a lot of difficulty. So that is called as tripod sign. Okay, so tripod position or tripod sign. Tripod is actually what is used for holding cameras. ऐसा होता है ना? So the child will also be on his hands in order to breathe. Is this an emergency situation or no? Anyone? Is this an emergency situation? Any idea? Acute epiglottitis, and how will you treat it? What is the treatment? Yes, absolutely correct. So this is an emergency situation because the child is in acute respiratory distress. What will you give for treatment? No, Sachidanand, parainfluenza is not the cause of here. Yes, so you will have to give antibiotics because this is a bacterial cause. So you'll give antibiotics for the treatment. And to reduce the inflammation of the epiglottis, you can give nebulized adrenaline. So that will cause vasoconstriction and it will help in reducing the edema of the vocal cords, edema of the epiglottis. Okay, so the child will be able to breathe well. Okay, another child walks in with similar symptoms. So you have another child with fever, sore throat, dysphagia, and stridor. Identify what is the problem in this case. Croup laryngitis, posterior pharyngeal abscess, or epiglottitis. Yes, you cannot give steroids in the previous child. It will lead to flaring up of the disease, in fact. All right. So everyone who's answered posterior pharyngeal abscess, you're absolutely correct. So if you have a look over here, you can see that in front of the vertebra, this is the retropharyngeal space. The space is enlarged a lot. Okay, so that is why you can say that there is a retropharyngeal abscess or a posterior pharyngeal abscess that is present over here. The child will often present with, yeah, there is widening of this retropharyngeal space. Okay, all right, so that's absolutely correct. And the last question for today, another child comes with similar symptoms and the following X-ray. What is your diagnosis? Croup laryngitis, posterior pharyngeal abscess, or epiglottitis? Yes, absolutely correct. So all of you have diagnosed this correctly. So can you see there is a steeple over here, like the top of the church? That is the meaning of steeple sign. So you see steeple sign over here, that is nothing but croup. What is the causative organism that is causing this? Most common cause of croup and the other name for croup. Yeah. So this is a viral disease. It is caused by para-influenza virus. What is the other name of this disease? It is also called as LTB. What is LTB? LTB is nothing but laryngotracheobronchitis. Laryngotracheobronchitis. Okay. Treatment batao. Treatment is nebulized adrenaline. Okay. Yeah. In this case, as compared to in acute epiglottitis, the patient will not have such acute respiratory distress. In case of croup, he will be sort of okay. He will be having fever and all other problems, but he will not be that bad, okay, as compared to acute epiglottitis. Acute epiglottitis is an emergency. Croup is not an emergency, okay? Okay. So that's it for today, guys, and I shall see you tomorrow at 6:30 p.m. Every day we will be having these case-based scenarios at 6:30 p.m. So make sure that you guys are all there on this Telegram group. Let's crack NEET PG, and I will send you the link to the class over here. Okay. So thank you so much, guys, and I shall see you next time. Bye bye. Tomorrow 6:30 p.m.